Welcome to Podcasts on Demand, a continuing medical education activity. If you are seeking continuing education credit, please review the disclosures and the requirements for successful completion of the activity prior to listening to the podcast. A link is found in the podcast description that can direct you to this information.
Welcome to episode 1 of 2 of the Expert Insights on Vitiligo. How do emerging treatment options have the potential to transform patient outcomes podcast series? I'm Dr. Chovatiya, and I'm joined by Dr. David Rosmarin. In this series, we provide expert interpretation of new exciting data for current and emerging treatment options of vitiligo, along with practical considerations for how new agents can impact patient outcomes. A case presentation is discussed to help clinicians select the most appropriate treatment as well as address the significant health burdens and complications experienced by many patients during treatment. It's important for clinicians to recognize common and uncommon presentations of vitiligo and those with active disease, as well as their implications for clinical management. These will be discussed within the case presentation.
So now we're going to talk a little bit about the pathophysiology of vitiligo, which has been better elucidated more recently. It's really interferon gamma that is driving the pathophysiology. So just to review some of the results from these cytokines is that we know that when you have a disease like psoriasis, that's Th17 driven, and cytokines like interleukin 23, interleukin 17, and TNF are really key cytokines in the pathophysiology of psoriasis. In contrast, we have atopic dermatitis, which is primarily a Th2 driven disease. And some key cytokines are interleukin 4, 13, interleukin 5 and 31 are also involved. Interleukin 31, sometimes we refer to as the itch cytokine. So that's where interleukin 31 comes in. And in contrast, vitiligo is fundamentally a Th1 disease. It's interferon gamma driven. And there's some kind of stress that can be triggering to the pathophysiology. But ultimately, it's interferon gamma that's signaling to our T cells through the JAK-STAT pathway, particularly JAK1 and JAK2. And it's those T cells that are then going back and destroying the melanocytes. Now, some other signaling molecules that are involved can be these signaling chemokines like CXCL9, CXCL10, which are involved with recruiting those CD8 positive cytotoxic T cells to destroy the melanocytes. But fundamentally, that's the problem. And I also want to comment that even after we treat vitiligo, sometimes the disease comes back. And why is that? Well, we have these resident memory T cells that are still remain, which are dependent on interleukin 15. So based on these cytokines and these signaling molecules that are involved, well, that's where we're going to try to target to get our patients better. And through the work of our scientists, really to elucidate that it's the Th1 pathway, that's really the key at helping develop new emerging therapies that are going to be effective for our patients. Back to you, Dr. Chovatiya.
Thanks, David. So that kind of takes us to what is going to be the central core aspect of our presentation tonight. And we're going to try to walk everybody tuning in through a pretty typical case on something that Dr. Rosmarin or myself might see in clinic on any given day, and hopefully use this to elucidate some of the more practical principles that we think about when it comes to vitiligo. So here's our case. A 30-year-old female, hypothetical patient, of course, and we're going to talk a little bit about sort of her history, some of our assessments, physical exam, and treatment that we end up thinking about for her. So let's get started. We have a 30-year-old female. She presented to the clinic with loss of pigmentation on the forehead, the cheek, the eyelid, hand, left arm, left foot, and axilla. Already great history because you documented all the body parts where something was going on. You'd be surprised how often we just talk about depigmentation. So another key point, really keep track of what's going on in your medical documentation. First notice these depigmentation happening about 18 months prior to the clinic visit. So it's been about a year and a half. Started on the dorsal hands and it's been progressing to other new areas of involvement appearing over time. There's no itching, burning, or other symptoms in the area of concern, and we talked a little bit about when you might expect or not expect symptoms. All the areas were distressing to her, most notably in the area around the eyes. This made her feel very self-conscious, embarrassed, and really some difficulties in socializing. In her own words, she said, "I knew it was going to be a problem when I just finished lunch with a friend and she said you have something on the side of your mouth." Otherwise, she's been feeling well, but worried that the depigmentation would continue to spread. Another point I'll make about this medical history, very, very thorough, and we can all sort of learn from the challenge of documenting this much, particularly when thinking about some of the aspects of burden that this disease causes in patients. So let's think about some of the other history elements. There's no known allergies. She works as a social paralegal, mostly office work, occasional travel, never married, and no offspring. So she has one sister with systemic lupus erythematosus. Her father had thyroid disease, and she denies any other history of atopy or autoimmune disease or family history of similar skin changes. She enjoys the occasional alcoholic beverage. She's a non-smoker with no exposure to secondhand smoke. She regularly eats junk food, woman after my own heart, and frequently visits tanning salons. Her medications are pretty simple, basically OC and a multivitamin. She's tried triamcinolone 0.1% ointment. So this might be a common story for someone coming to see us at the recommendation of her primary care physician and did not notice any improvement. She could not recall any significant changes in medications or personal care products in the months preceding the onset of skin changes. So I'll say, just highlighting a couple of elements of what we just talked about, this idea of duration, treatment, burden, some of the other stuff in your life. This is kind of the classic stuff that you really want to do a good job of documenting and capturing for anybody that might be presenting with depigmentation as a potential complaint.
Yeah, so you hear that family history of lupus, and you might say, well, I may want to check in an ANA, given the fact that the lupus is running in the family, and maybe my suspicion would be a little bit higher. Well, is there concomitant connective tissue disease? This person is going to be at higher risk. But would that help with the diagnosis of vitiligo? And typically not. Then the Woods lamp is a UV light that helps enhance the contrast between the depigmented and normal skin. So that if you see that contrast enhancement on Woods lamp, it helps tell you that there's depigmentation and this is vitiligo. As opposed to if it were just hypopigmented, you wouldn't see that contrast enhancement. Also, it's especially important to use a Woods lamp on somebody who may be skin type 1 or 2, where it can be really hard to see the extent of the vitiligo. Some patients don't realize how extensive it is, and may also often get emotional if they start to see that it's more than they thought it was when they first came in. Now, in terms of a skin biopsy, that can be helpful, but really in very rare occasions. If you take a skin biopsy of vitiligo, you see an absence of melanocytes. However, usually we don't need to do that for diagnosis, and Woods lamp and clinical picture is enough for the diagnosis alone. But there may be certain circumstances when the skin biopsy.
Yeah, I'll throw it out there and say that if there's a differential diagnosis of some sort, then you're thinking about hypopigmentation or even depigmentation associated with potentially some other inflammatory cause. It's not unreasonable, but for sort of most rank and file vitiligo cases, clinical diagnosis is typically sufficient.
So when I see a patient who has vitiligo, I am asking myself several things. Well, one is, does this fit the typical clinical picture, right, which is often symmetric? Is it completely depigmented, or is it early vitiligo that's evolving to be completely depigmented? Does it have those typical locations? Also, I'm asking myself, does the person have a family history of vitiligo? So a patient is about 6-fold more likely to have vitiligo if they have a first-degree relative that also has the disease. And one of the questions I often get is, oh, doc, will I have kids that have vitiligo? And the chances are probably won't happen. It's about a 4% risk for somebody who has vitiligo to have a kid that has vitiligo. And so I think that's important, that people shouldn't be fearful of that, but that is higher than the baseline population. Also, I may do some review of systems to see if there's a risk for any comorbidity. So the most common comorbidity by far is autoimmune thyroid disease. So either overactive or underactive Hashimoto's or Graves'. That's by far the number one comorbidity. It's seen in up to 25% of patients have vitiligo. Now, whether we do a TSH screening or autoantibodies, that's somewhat controversial. Some people will do it, some people don't. Do you check a TSH, Dr. Chovatiya?
Yeah, I mean, I think that I historically used to always do it in every patient, but then I started at least being a little more limited, thinking about medical cost and burden and making sure, am I looking at an age group where this is relevant and other historical concerns I might have where this is relevant. So I still think that there's a lot of value in the test, but at least pausing before ordering a lab can be helpful in my case.
Now, I commonly check a TSH at the first visit that I have a patient with newly diagnosed vitiligo, or if they've had it done recently, I won't recheck it. But just because it's very common in this patient population. The other autoimmune conditions are much less common in general, such as pernicious anemia, such as type 1 diabetes. And therefore, I wouldn't do a screening test for those autoimmune conditions, but just what's appropriate based on review of systems. In terms of what else we're doing, it's really important to find out how extensive the disease is for a patient and try to get a rough body surface area. And then also determine, is the disease active or is it stable? That's really critical and helps determine next steps. So I'm looking for those 4 signs of activity and asking the patient, has this been spreading? But sometimes patients don't know. And again, just to review those 4 signs: trichome vitiligo, confetti lesions, Kedner phenomenon, or inflammatory vitiligo. So if I see one of those 4, I'm concerned that this is active, and I'm going to want to address it, and we'll discuss how to do that in the next session. Now, one of the key aspects to vitiligo is the fact that it's depigmented, not really hypopigmented. So one of the things that people will come in thinking that they have vitiligo is if they have pityriasis alba. So if you see a kid with a history of eczema or atopic dermatitis with hypopigmentation bilaterally on the cheeks, they can be reassured that this is pityriasis alba. Sometimes patients are concerned because of tinea versicolor, which can also be hypopigmented, but really not depigmented. And that's, again, where the Woods lamp can be extremely helpful. And I think those are probably the 2 most common conditions that patients come in with, thinking that they may have vitiligo. They may have Googled it and say, oh, this is what I have. But always helpful to keep in mind the differential.
So let's kind of continue with our case here. Okay, so let's touch on the physical exam first. The assessment tells us that there is depigmented macules and patches on the dorsal hands, left forearm, left dorsal foot, the axilla, the forehead, both eyelids, periorbital region, and the lateral cheeks. There's no erythema within the depigmented areas, which is important based on what we just talked about in terms of inflammatory lesions. Skin temperature in the affected areas felt normal. The total BSA was approximately around 2% or so, which we know is kind of a gestalt measure that's used in day-to-day clinical practice, even though it's tricky to really sort of calculate something sheerly by BSA with vitiligo. The patient couldn't identify any other exacerbating alleviating factors, and other lab tests and skin biopsy were not particularly indicated in this patient. So just one point that we'll bring up, and again, this is sort of taking a look at the vitiligo lesions, and we just talked a little bit about the Woods lamp in terms of accentuation of those areas of pigment loss, which is kind of what you're seeing in this photograph over here for just a little bit of context.
So I think that picture that Dr. Chovatiya showed really nicely highlights what you can see on Woods lamp, really highlighting that depigmentation, that enhancement within the picture. Now, I always like to put down a rough body surface area, and we commonly think of body surface area using hand units, particularly for the body, where the palm, it's the patient's palm, is about 0.5% of the patient's surface area, and the whole hand for the patient will be about 1% of the body. Now, in clinical trials, we may use the VASI, the Vitiligo Area Scoring Index, as a tool, but it's really not done within the clinic because it's more cumbersome to do within a busy schedule. So what the VASI score is intended to do is measure the amount of depigmentation, and the key is depigmentation. If a patient is hypopigmented, that is, or hyperpigmented, that's not counted within the tool. It's only the amount of depigmentation, and it's the surface area times the degree of depigmentation. So if within a patch of vitiligo, there's some follicular repigmentation, well, then that gets subtracted out, or really it's multiplied by some multiplier. And that's what the VASI score is. The VASI has also been modified for the face, which we call the F-VASI, as opposed to the total body, which would be the T-VASI. And because the face occupies up to 3.5% of the total body surface area, that's the maximum score for the F-VASI, would be 3.5. Now, you've heard of the PASI score and EASI score, which are analogous. Those scales go from 0 to 72. Whereas the total VASI goes from 0 to 100 because it's a body surface area score. So if you have total complete depigmentation, well, that would be a VASI of 100. And similarly, if you have half of your face that's depigmented, well, then that would be an F-VASI score of 1.75.
So let's just touch on the ending part here of our assessment of the patient. We've asked about signs, symptoms, medical history, done an exam. In terms of some of the comorbidities here, TSH as well as TPO and TG antibodies are tested and found to be within normal limits. So it doesn't seem like thyroid disease is of major concern to our patient at the moment.
So how would we treat a patient like this in vitiligo in general? Well, the first thing that I mentioned I try to assess is the vitiligo spreading or is it stable? Very important to determine that. Now, if it's spreading, my first goal is to stabilize the disease. And the primary way I would do that is with oral corticosteroids. And there are studies showing that dexamethasone, about 2.5 milligrams, given on 2 consecutive days for about 12 weeks, stabilizes disease in about 90% of patients with really minimal side effects. So I think that's one of my main strategies. Now, if that were not to work, you could always try doing that for longer or increasing the dose up to 5 milligrams of dexamethasone on 2 consecutive days for another 12 weeks or so. Now, another option to help stabilize the disease and can also help start the repigmentation process would be phototherapy, particularly with narrow bands, UVB. So those are the 2 main options we have for helping stabilize our patients in terms of the vitiligo. Now, once we accomplish that, the next question is, well, how do we help treat these patients really effectively to help with the repigmentation process? And for that, we are basically dividing patients into those who have very localized disease where topical makes sense, so maybe 10% or less of the body surface area, or patients who have more extensive or generalized involvement. For patients who have more localized disease, we're thinking about topical treatments. And that includes really 3 main options. 1, corticosteroids, calcineurin inhibitors, particularly tacrolimus ointment, and then 3, ruxolitinib cream, which is currently the only FDA-approved treatment for repigmenting non-segmental vitiligo. Now, if patients have the disease more moderate or severely, we may also discuss with them more systemic options, such as narrowband UVB phototherapy. And some key there is that it's not the frequency of treatment, but the total number of treatments that patients get that's ultimately responsible for their final result. Also, some people may use oral JAK inhibitors, which are off-label. In terms of using PUVA, that's really not used as much anymore because our studies show that narrowband UVB is more effective than PUVA. So we really discourage that use. Other options that we also look to more as 3rd and 4th line treatments can be basically melanocyte transfer. So if a patient has stable disease, and we're sure it's stable, and they don't have the Kevner phenomenon, and they have a small area, they may be a candidate to take melanocytes from normal skin and transfer them over to the depigmented areas, and patients can have great results that way. And then lastly, for certain candidates that may want complete depigmentation, we have certain options such as monobenzone. However, there are very few people who really fit as good candidates for that option, but the ones who do it can have quite high patient satisfaction. Now, one thing that we're also in the process of studying is concomitant treatment. So it may be that topical treatments or systemic medicines that help suppress the immune system combined with phototherapy may even be better than either alone. And so that's currently under investigation, and we think that strategy might work. So utilizing our topical corticosteroids, calcineurin inhibitors, or JAK inhibitors with narrowband UVB phototherapy or excimer laser is often our go-to option for our patients. If patients can't do the phototherapy due to inconvenience, and perhaps just starting out with one of our topicals. Thank you, Dr. Chovatiya.
So let's kind of jump into some detail about what Dr. Rosmarin just told us about. And so in general, treatment is centered around a few simple principles. We're trying to essentially stabilize disease, so stop depigmentation. We're then trying to drive repigmentation and get us to a point where things can stay stable. And so as you can imagine, this is a multi-step process, so this takes time. We're so used to thinking about a world in dermatology that's on the order of weeks, even a few months, but this whole process is a multi-month, if not longer process. So in terms of really trying to get rid of that oxidative stress, correct an aberrant immune response, and create an environment where melanocytes can regrow and proliferate, you're really trying to do a lot of things with vitiligo therapy. So there's a lot of different things that can impact therapeutic outcomes. Some sites of the body tend to repigment better than others. A lot of this has to do with follicular density, knowing that that is the reserve around the follicle region where many of these melanocytic progenitors might reside. So something like the face does a way better job than, let's say, somewhere around the hands where there really isn't sort of that much density going on. Additionally, there's other factors to touch on in terms of sort of how long someone may have had disease, how old they are, sort of the duration of therapy, whether or not you're seeing sort of total whiteness of the hairs or lesional white hairs, leukotrichia. Typically, that's a sign that there really isn't any pigment left in that reserve, meaning that you're not really going to be able to get functional melanocytes migrating out and repopulating an area. Additionally, confetti lesions and trichrome lesions as signs of really rapidly progressing disease as well are things to look out for. Now, we talked about some of those topicals, and let me kind of review what we used to have before Dr. Rosmarin jumps into sort of some of the newer stuff. In general, topicals are first-line therapy for limited disease. Maximal repigmentation of face and neck is kind of what's clinically been observed. Topical corticosteroids, of course, are readily available, fairly cheap, and found in a variety of different formulations. They seem to work when you combine them with narrowband UVB as opposed to by themselves, where they're not as effective relatively. Usually your maximal results are happening somewhere in the mid to high potency preparations. You are going to be limited by potency for particularly sensitive body areas, just like the face. Chronic topical corticosteroids can drive atrophy, acne, telangiectasia, loss of subcutaneous fat, even sort of other pigmentary problems on pigmented skin as well. So something that is just a major drawback for chronic topical corticosteroid therapy. We know that with calcineurin inhibitors, they also have efficacy that's been documented over time, also particularly alongside light-based therapies like narrowband UVB or Excimer. You don't have the steroid-related complications, which is nice, but there can be other cutaneous adverse events like sort of stinging or burning that can go along with calcineurin inhibitors that can limit their use in some individuals. Additionally, long-term use in maintenance therapy, that's kind of a place where they shine. And sort of some individuals will try this initial approach with a stronger topical steroid, then pull back from maintenance with topical calcineurin inhibitor. Phototherapy is another really important modality. I know Dr. Rosmarin uses it quite a bit. I do as well across inflammatory diseases, but particularly in vitiligo. We know that narrowband UVB especially is the one that balances efficacy with safety in terms of sort of relatively low to not really any sort of definite documented skin cancer risk compared to PUVA, which was a UVA-based therapy that involved the use of a swirlin as well, which was historically used quite a bit, but does have certain risks and limitations on how long you can use it. So you can see here in this meta-analysis of a number of studies, there was actually a pretty moderate response in about 37% of individuals at sort of 6 months and 57% at 12 months, and a marked response sort of in sort of relatively good numbers as well, but particularly with the longer treatment. And you can see that this extended sort of not only across the face and neck region, but other body areas. As I mentioned, the hands and feet in general just are oftentimes very, very tricky when we're thinking about driving repigmentation. Autologous grafting is another one that's worth mentioning, noting that this isn't going to be a technique found everywhere. It's usually going to be specialized areas. And so stable focal and segmental vitiligo can be helpful here when you have areas that are not responsive to medical therapies. You could have suction blister grafts, melanocyte transplants, punch grafts, sheet grafts, essentially trying to take healthy melanocytes or particularly melanocytic progenitors into areas where they don't exist and allow their proliferation. So that's kind of the grafting aspect of it. And you can graft tissue or cells in a variety of different ways. Maximal results, of course, are going to be used in conjunction with phototherapy. There is some long-term follow-up that suggests this could be beneficial, but as you might imagine, given this somewhat of a physical modality, there can be limitations on where you might potentially be able to get this type of treatment. So in the case of our particular patient, she's tried topical corticosteroids without relief. She's had extensive periorbital and eyelid involvement, making those not great options for her. She's used topical calcineurin inhibitors, the tacrolimus that was mentioned by Dr. Rosmarin. Really no appreciable improvement after 3 months of twice daily use. Let's talk a little bit about the last part of this case, and then we're going to get into JAK inhibition and signaling with Dr. Rosmarin. So for this patient, ruxolitinib 1.5% cream, a topical JAK inhibitor that is indeed indicated for non-segmental vitiligo. Remember those words and document them well. Was prescribed to be applied twice daily to the affected areas. Take it away, David.
In order to understand why JAK inhibition and ruxolitinib cream makes sense, we have to go back to the pathogenesis. And vitiligo is fundamentally an autoimmune disease. And key is that it's not a cosmetic condition, it's a medical condition, it's an autoimmune condition that's driven by Th1 cytokines, particularly interferon gamma. And how is interferon gamma signaling? Well, when it binds to the receptor on the T cell, it then signals intracellularly through JAK1 and JAK2, which activates the STAT and causes a transcriptional programming, which leads to killing off of the melanocytes. The key to this positive feedback loop and part of the problem with vitiligo is that the signaling is taking place through JAK1 and JAK2. So if you block JAK, you're blocking the interferon gamma signal, which is what will help patients get better when they have vitiligo. And you may say, well, don't our other topical treatments do that? Well, corticosteroids and calcineurin inhibitors, well, they can be good at certain disease axes, like for eczema and for psoriasis. They tend to not really work well when it comes to interferon gamma suppression. And that's why JAK inhibitors really play a particularly well-suited role for vitiligo, is because they have very good activity when it comes to suppressing the interferon gamma axis. So again, vitiligo, it's fundamentally autoimmune in nature. JAK is part of that signaling pathway through interferon gamma. And ruxolitinib cream is our first and currently only FDA-approved treatment for patients with non-segmental vitiligo. And it's approved for both pediatric and adult patients that are 12 years of age and up. It's used twice a day. And we have both short-term and long-term data showing its efficacy and safety, which we're going to review. So this was the primary endpoint for the two phase 3 programs, TruV1 and TruV2, which were identical. The primary endpoint was at 24 weeks, and that at that time it was vehicle control, but then at 24 weeks, all patients received ruxolitinib cream, and we have more data for the 52-week mark. And we can see here that in both studies, about 30% of the patients achieved this FAAD 75 at the 6-month mark, but it jumped up to about 50% of patients at the year mark. So you can tell about half of your patients are going to get 75% or more of their pigment back on the face at a year. And that's very consistent, not only amongst the phase 3 results that we see here, but also amongst the phase 2 results that we see. It's very robust, that number, that's about the percent of patients that improve. And the key with discussing with patients is not to rely on the 24-week mark, because unlike other conditions such as psoriasis and atopic dermatitis, where most of the improvement happens early, in vitiligo, the repigmentation process takes time. You really want to make sure that patients are getting it not only a year, but even up to 2 years, really, for improvement, because our studies show that even more benefit is gathered by our patients beyond the year mark. Also, some of our studies show that in patients who are partial responders, well, they can still achieve an FAAD 75 if they still are using the medicine beyond the year mark. So I think that's all really important information to give to patients and counsel them about their expectations. If they expect to get better in 3 months or 6 months, that's not the right expectations. They really need to go into the mindset that they're going to be using this for about 2 years. Some patients may even need more. But with continued use, we're seeing continued benefit. Now we're going to look at some pictures of patients who use ruxolitinib cream in the phase 3 program. So this individual had about half his face or more depigmented with vitiligo. We see at baseline. Already at 12 weeks, we see significant repigmentation, and by the 6-month mark, really is largely repigmented. This would be a very early responder that was from the study. The next patient we have is a teenager who had depigmentation around the eyes, nose, and mouth. And at the 12-week mark, you can see significant repigmentation around the eyes, but then not until the 24-week, and I think this is mislabeled. It's actually week 52. Oh, sorry, this is correctly labeled. In week 24, we see really nice repigmentation around the eyes, but the mouth is not fully repigmented yet. What I will comment on is knowing this patient is that at week 52, she then did get her pigmentation back fully around the mouth. What I also really like about this picture is you can also see one of the side effects of ruxolitinib cream. About 6% of patients will get application site acne. And here she has a little bit of acne at baseline. You can see that in her forehead. And perhaps it's a little bit worse at the 6-month mark in the cheeks. Now, all the patients, it's really mild or moderate. No patients had to drop out of the study due to this. And really, in my experience, patients don't discontinue the treatment. It's usually mild, and we can treat it with the normal ways that we use to treat acne. Here is a patient whose hands also showed improvement. As we now know, ruxolitinib cream is not just for the face, it can help improve the body. And even though the hands are a very recalcitrant anatomic site, patients can still get improvement there. Here we see an extremity that's also repigmenting in nicely in the follicular way. But the right advice for this patient at week 24 is to keep using the medicine. They haven't hit their maximal response yet. In terms of some key findings from ruxolitinib cream, it's that we're seeing even more patients improve with continued use of the medicine, so that even though it's 50% of patients achieving an FAAD 75 at the year mark, we're seeing even higher numbers at the 2-year mark. And it's also the same is true for the body as well. Patients who are not super responders on the body, with continued use of the medicine, they'll see continued improvement. So on average, about half the patients at the year mark will have a 50% or more improvement on the body. Sorry, if we look at the data, about 6% of patients in the study had application site acne, almost always mild or moderate and not leading to discontinuation of treatment. Also, about 6% of patients can have application site reaction like pruritus. And again, these are also often mild. One of the reasons why we like to use ruxolitinib cream as a topical is because you help minimize the risks of a systemic agent. So we weren't seeing wholesale neutropenia, anemia or other side effects, which may be uncommon, but you can still get with systemic JAK inhibitor use. And oftentimes I'm asked, do I monitor the blood with patients who are Rux cream? And the answer is no, because it was these side effects were monitored in the phase 3 study, and we weren't seeing signals for lab abnormalities. I don't check it in clinical practice either.
So let's touch on some of the emerging strategies before kind of David and I put it all together. And I don't want to spend too long on this, other than to say, if we had sort of talked about the vitiligo treatments a few years ago, there would have been much to talk about, number one. And number two, there probably wouldn't have been this kind of flurry of activity that you see in front of you. But now there's a lot of really cool, interesting emerging data for several JAK inhibitors across a variety of different phase 1, 2, and 3 programs. And I know that I'm particularly excited for the prospect of not only sort of topical agents, but oral agents too. So some of the most recently presented data that probably is very exciting on here is ritlecitinib, a JAK3 and TEC inhibitor. There was recent presentation of upadacitinib data for phase 2 just last week, actually, in terms of vitiligo improvement. And vorasitinib is another oral JAK inhibitor as well that's had some others. But you can see here there's additional treatments that are being looked at in the case of vitiligo. So really exciting things to come for our patients. I want to touch on kind of the ending of our case for a little bit of closure. And our patient returned 6.5 months later. She was excited and optimistic by the amount of repigmentation, especially around her eyes, no side effects. The physical exam was consistent with everything you heard Dr. Rosmarin talk about. And there was some patchy areas of depigmentation. And she's not yet started using it on other affected body parts, but really is motivated to do so. And she states that she's relieved and excited to continue the medication to try and achieve full repigmentation in the areas that caused her distress. So I think the big conclusion here is that you want to make sure that you are sticking with your patients, getting them to come back in reasonable timeframes, setting the right expectations based on the data, and really sort of being a cheerleader in some ways, because this is going to take its time to work. And in this particular case, you can see here 6.5 months, reasonable time frame is when this patient is really starting to feel optimistic about the changes that she is seeing. And you can already see that quality of life and probably even mental health is so connected to that improvement that this patient is getting. So with that being said, let's kind of wrap things up with some closing thoughts here first. So a couple of things that I want to touch on, David, and then sort of I'll let you sort of add yours as well, is that really vitiligo is about the whole person. It's not just what you see on the skin. It's not just the pigmented patches, but in this particular case, quality of life, mental, physical, psychosocial burden, and mental health symptoms in particular are key. And you have to understand that, like a lot of other inflammatory diseases, you really need to look beyond just what you see on the skin. That psychological burden, for instance, is just the one that's so well documented. And there is a fascinating history of vitiligo and the way that it's created unique burden in various cultures and civilizations throughout history.
So I can't echo that enough, that what Dr. Chovatiya said is that this can have really a big effect on patients, and it's really important not to make assumptions either. So you may think that a patient who is very fair-skinned is not affected by the vitiligo, but they really might be. Similarly, some patients who may have very noticeable vitiligo but aren't bothered by their disease. So you never make assumptions and always need to have that shared decision-making process with patients. In terms of the pathogenesis, we really have now well established it's fundamentally a Th1 disease driven by interferon gamma through the JAK-STAT signaling pathway. Therefore, it makes a lot of sense to think about a JAK inhibitor as a treatment, and it's been proven to work not only in multiple studies with the topical, but there are now systemic oral JAK inhibitors that are also proven to help repigment patients with vitiligo. So key points here are that you can make a big difference in these patients' lives, not to make assumptions, and really help them out in a compassionate way that dermatologists know how.
Hopefully you enjoyed what we brought you guys tonight. It was a real pleasure, David, to participate with you and sort of taking a really rapid fire look from top to bottom at vitiligo and really thinking about where we've come and where we're going. Thank you for listening to this episode of Expert Insights on Vitiligo. How do emerging treatment options have the potential to transform patient outcomes?
We hope you found this podcast useful and educational.